2, 1. Please start, so we are live.
Good evening, everyone, and welcome to this virtual webinar on recent advances in oncology treatment 2024. To begin with, I would like to invite our program director, Dr. Manish Sharma, sir, who is consultant and head of unit of medical oncology at Positron Super Specialty and Cancer Hospital, Rohtak, to set the context. Over to you, sir.
Good evening. Thank you all for joining at this evening for the webinar on the latest treatment updates in lung cancer. So this is the most common cancer that we see today as of now. We will be starting with Dr. Praveen. Dr. Abhishek is late somewhat. So Dr. Praveen is consultant and head of medical oncology department at Akash Institute. He will be speaking on the advanced NSCLC treatment in today's era. Dr. Praveen, please welcome.
So thank you, Dr. Manish, for giving me this opportunity. Let me share my screen. I hope my screen is visible.
Yes, Dr.
Sir,
Praveen.
it is with you.
Okay, let me put on. Okay. So thank you for inviting me to give this talk. So I'll be speaking on advanced EGFR mutated non-small cell lung cancer, evidence-based review of targeted therapy. Lung cancer, as per the Globocan 2020, was the second most common cancer diagnosed in males and third most common cancer diagnosed in females. And it contributes to most amount of or most number of cancer-related death in males and second most number of death in females. In India, it is the fourth leading cause of cancer-related death and fourth among the cancer incidents also. So it is visible from this slide that it is one of the most common cancer and it leads to a lot of morbidity and mortality. Stage-wise distribution, if we look at the 5-year overall survival according to that, stage 1, so it is from 77 to 92%. Stage 2 is somewhere around 26 to 60%. And stage 3 is almost 30%, 20 to 30%. And there are hardly 10% patient in a stage 4A disease who have a 5-year overall survival. And this is with traditional or conventional therapies. Looking at the stage-wise distribution of cases, stage 1 and stage 2, they contribute to 5%. Stage 3 is almost 30%, and most of the patients, 2/3 of the patients, they present with a stage 4 disease. So there are biomarkers which we are supposed to see in lung cancer. So there are predictive biomarker as well as the prognostic biomarker. I'll not go into the detail of this. We all know this. So in non-squamous histology or non-small cell non-squamous, so the most common genetic aberration. So these are EGFR and ALK. And if we look unselected non-small cell lung cancer patient, so almost 1/4 of the patient, they also have KRAS mutation, which leads to increased tumor cell proliferation. And half of these KRAS mutation, they are G12C. So where we have a targeted therapy available for this. So the most common genetic aberration which we are able to see in our clinical practice. So these are EGFR, ALK, KRAS, ROS, MET, RET, NTRK, then PIK3CA and BRAF. So these are the testing modalities which are to be used in most common of these molecular aberrations. So for EGFR, PCR or the NGS based testing modalities, so they are the best. ALK, only Ventana IHC is approved. Other than Ventana, so there are no IHC which are supposed to be used as a confirmatory method. Even if you do some other IHC modalities, it has to be confirmed with FISH, except for Ventana, Roche Ventana. And the fish again is gold standard for ALK gene rearrangement. However, we have seen that numerically more people are diagnosed with ALK rearrangements with Ventana IHC as compared to the fish. So ROS1 IHC is the most sensitive methodology, and it is the screening test which is being used. And later on, if the IHC is positive, so it is confirmed with the fish. PDL1 only IHC is the recommended method. Fish and PCR based assays they do not because it's a protein. Regarding the EGFR driver mutation, the tyrosine kinase domain, it is coded by exon 18, 19, 20, and 21, out of which exon 19 and exon 21 together, so they are the most common mutations. And the mutation of exon 18 to 21 or EGFR, so they are classified into common and uncommon mutation. Exon 19 plus 21, they are common, and rest of the mutation, they are uncommon mutations. Exon 19, it is basically deletion in codon 746 to 750. Exon 21, these are substitution mutation where L858R or L861Q, so these are the most common mutations. Apart from that, there are certain uncommon mutations like G719 mutations or S768 mutations, so which are also seen in exon 18 and 20. So there are exon 20 insertion also, which we are more and more identifying these days with the advent of comprehensive genomic profiling. It is seen that there is a wide geographical variation as far as the prevalence of EGFR mutation is concerned. So it is seen Asians, they have more EGFR mutations as compared to Caucasians. But if we look at the stage-wise distribution of EGFR mutations, so they hardly vary. So there was an initial thing just like MSI H or MMR deficient disease in colon, where MSIH was more common in the earlier stage as compared to the advanced stage. So vice versa was thought to be in lung cancer, where we were thinking that stage 1, 2, 3, the EGFR mutation is less common as compared to the stage 4. But this was the study which showed that the incidences of EGFR mutation, so they are consistently the same, be it a stage 1 disease or a stage 4 disease. NCCN also recommends that molecular testing of EGFR mutation should be performed whenever the patient is undergoing the surgery or whenever the patient is having a metastatic disease. So because these therapies, so they have made impact in the outcome of the patient whenever used in the corresponding scenarios. So EGFR wild type versus EGFR mutation wild type, we can see whenever the EGF bind to its receptor, so the pathway activation happens, which leads to more cell survival proliferation. But in a mutated EGFR state, so the tyrosine kinase domain, so they are constitutively active and they do not require the binding of EGF to EGFR to activate the pathway. So because of this constitutive activation, the pathway is already always in activated phase, and there is constant signaling towards cell survival and proliferation. So this is the difference between the EGFR wild type and mutated. So these are the first line biomarkers which are supposed to be tested before we go ahead with the first line therapy. In non-squamous histology, so we have to test the patient for EGFR ALK-ROS so as to select what sort of therapy we are going to use. And there are broadly two kind of approaches or two different verticals of treatment in non-squamous histology. One is where the patient is having a oncogene driven tumor, and the other one is where the patient does not have an oncogene driven tumor. The oncogene driven tumor, they are drive the treatment is selected on the basis of the biomarker testing, And in non-oncogene driven tumor, the treatment is selected on the basis of PDL1 assay. So what is the positivity of PDL1? If it is whether the patient is expressing a PDL1 or a high expressor of PDL1, we can select either chemo along with immunotherapy or immunotherapy respectively. For biomarker driven therapies, so whatever target comes out to be positive, we have a lot of option nowadays. Suppose if we have EGFR mutation, we have 3 generation of EGFR TKIs. If we have ALK, so we again have 3 generation of TKIs, and depending on whatever is feasible for the patient, we can select the agent. For squamous cell histology, uh, if usually what we do is that if a patient is a non-smoker, again we go ahead with the biomarker testing. So, but here the positivity rate of biomarker testing is quite low, and we also do PDL1 testing at the same time parallelly. And if the patient is biomarker positive, so we treat the patient with a targeted therapies, and if the biomarker is negative, we treat with chemo with or without immunotherapy. So osimertinib, it is a irreversible inhibitor of EGFR EGFR tyrosine kinase, and we can see that it only inhibits the EGFR mutated and EGFR T790M receptors. It does not inhibit the wild type EGFR. So that is the reason why it does not have lot of wild type inhibition side effects as compared to the other agents. So FLORA was the registration trial for osimertinib in the first line non-small cell lung cancer, EGFR mutated. So they had included patients with locally advanced unresectable tumor or metastatic non-small cell lung cancer with common EGFR mutations with stable CNS metastasis. And they were randomized into 1:1 fashion to osimertinib versus EGFR TKI of choice, of physician choice. And the progression-free survival was the primary endpoint. We can see here that the baseline characteristics, they were well balanced in both the arms. If we look at the CNS metastasis, almost 19% of the patient in osimertinib arm and 23% in the SOC arm. So they had stable brain metastasis. This was the PFS analysis. With a 62% maturity, we can see the median PFS was 18.9 months versus 10.2 months in osimertinib versus SOC. And the hazard ratio was 0.46, again 54% reduction in the PFS events. This is the subgroup analysis where across the board, all the patients, irrespective of the subgroup, they had advantage in favor of osimertinib, and consistently it had shown a hazard ratio of 0.4 to 0.5. Objective response rates, one thing which I want to show you over here, that only 1% of the patient, they had a progressive disease when osimertinib was used. So there were hardly any progressors. But if we look at the objective response rate of OC versus SOC, so there was no significant advantage. Duration of response, there was significant improvement with osimertinib, and these patients who did well on osimertinib, so they did had a very durable kind of response. This was the final overall survival with the 58% maturity. We can see over here the hazard ratio was 0.799 with a p-value of 0.0462, which was statistically significant, and the median OS, the delta was 6.8 months, again clinically meaningful. Adverse events of osimertinib, so almost similar kind of adverse events, except the incidences of these ALT, AST increase. It was seen with more SOC arm as compared to osimertinib. So this is a very important slide which shows that those patients who have significant adverse events, so they were almost equivalent in osimertinib versus SOC arm. But if we look at the any adverse event of grade more than equal to 3, so then it was 28% in SOC arm as compared to 17% with the osimertinib arm. So this means that osimertinib is almost equally tolerable as compared to the first generation TKI, and or even in some instances it can be better also. So this was the conclusion of FLORA trial, where osimertinib had resulted in statistically significant and clinically meaningful improvement in progression-free survival, in overall survival, and there was a CNS PFS advantage, which we are going to see in the subsequent slides also. And the safety profile of osimertinib was comparable to SOC arm. So CNS efficacy, it's a very important aspect as far as the EGFR mutated disease is concerned. And it is seen that these EGFR mutated containing NSCLC, they have more tendency for brain metastasis. So it was seen that those patients with EGFR mutated disease at initial diagnosis, so 19 to 24% had brain metastasis as compared to 11 to 13% in wild type EGFR. And if we look at during final follow-up, so that means during the course of illness, so there are almost double CNS metastases which are observed as compared to the wild type EGFR, and almost 6 times more leptomeningeal metastasis as compared to wild type EGFR. So the efficacy of a drug in preventing these CNS metastases or treating these CNS metastases, it is a very important concern or a factor which we have to consider while selecting our therapy. So with CNS metastasis in FLORA trial, osimertinib showed that the median PFS with or without CNS metastasis at baseline, so it was absolutely the same. So hazard ratio, we can compare 0.47 in those with CNS metastasis and 0.46 in those without CNS metastasis. So in fact, so they also had seen that those patients who were not having any CNS metastasis, so fewer new CNS metastases were seen in these population, 6% in osimertinib versus 15% in SOC arm. So this was the CNS PFS. We can see the hazard ratio 0.48. Again, the CNS PFS was significantly prolonged with osimertinib as compared to SOC, and it was the median was not reached in osimertinib versus 13.9 months with the SOC. So this was the comparison. FLORA was the comparison of SOC, where only first generation TKI were selected. So what about the second generation TKI? So I'll show you some cross trial comparison of osimertinib versus second generation TKI. First with the dacomitinib Archer trial. So Archer 1050, if we look at the PFS curve, so there was initial 6 month which dacomitinib took, and the curve separated after 6 months. So, but we are not sure of why this 6 month window was there. So, there were few patients who progressed very early on dacomitinib, similar to gefitinib, and we do not know what are those factors which led to progression on dacomitinib. But if we look at the FLORA trial, so there was immediate separation within the first month only, and the curve widened as the time passes. So the median, again, the hazard ratio was 0.46 with the osimertinib and 0.59 with the dacomitinib, again better with the FLORA. And if we look at the median also, so median PFS was 18.9 months with osimertinib as compared to 14.7 months with dacomitinib. Overall survival, so the overall response rate, so Archer 1050, it was a very peculiar trial where they had a hierarchical testing design just to give the results early and uh, to keep the sample size under control. So they had used the hierarchical design, and it was supposed to be first ORR PFS followed by ORR followed by overall survival. These were the hierarchical testing which were supposed to be done. So PFS was significantly better, but overall response rate they were almost similar. So that was the reason that the formal overall survival analysis of Archer 1050 was not taken into picture, and there was numerically higher overall survival which was seen with decomitinib, but it was not given statistically significance because of the statistical design. Uh, Whereas if we look at the flora overall survival, so it was significantly there with a hazard ratio of 0.79, and it was statistically significant also. So this was the Canadian consensus. Again, they had commented on the Archer 1050 trial that the trial had a hierarchical stratified statistical design, and given that it did not meet significance in overall response rate, a p-value could not be given to OS, and the significance was not given to the overall survival advantage which was seen with the decomitinib. So coming to the second generation TKI OSI versus FA, so we can see Lux Lung 7. So this was the study where afatinib was compared with the first generation TKI. And we can see over here, so there was no progression-free survival advantage which was seen with this trial. And in fact, if we look at the hazard ratio, it was 0.73. The osimertinib had a median PFS of 18.9 months, which was statistically significant. Regarding the overall survival advantage, it was not there with the Lux Lung 7 and Aussie Flora we already know of. So regarding the, so there were some subset analysis which were also performed in exon 19 versus the L858R mutations. Exon 19 deletion again was almost similar to L858R. So yes, it was seen that the median PFS, median overall survival was lesser with the L858R, but comparing second versus first generation, there was no statistically significant advantage of both. So this is a very important slide where the third generation TKI was compared against second generation as far as the AEs are concerned. We can see significantly more dose reductions with afatinib and decomitinib, and almost two-thirds of the patients with decomitinib they needed one dose reduction, and almost one-third of the patient they need two dose reductions. And diarrhea, paronychia, skin rash, stomatitis. So these are the side effects which were more common with the second generation TKI as compared to osimertinib. And the reason behind this is because the second generation TKI they also inhibit the EGFR wild type and EGFR mutated also. So it is these side effects are because of the wild type EGFR inhibition, and this is the difference between osimertinib and the second generation TKI. So Flora study also looked at the sequencing arm. So there were few patients who were initially given first generation TKI, and later on they were on progression given osimertinib. Almost 47% of the patient they had crossover to osimertinib. So despite using that, osimertinib in first line was a better strategy as compared to the sequencing strategy. And there were other nuances of a second line strategy that almost one-third of the patient they never get an opportunity to receive second line therapy, and out of those 70% who get second line therapy, so almost 50% they will have a T790M negative status, so they will never be exposed to osimertinib. So this was the analysis where we can see on the left side. So it's the comparator arm patient disposition according to the second line therapy. We can see two-thirds of the patient they received second line therapy, and one-third of the patient they did not receive second line therapy. And out of those who received second line therapy, only 47% of the patient they received osimertinib as compared to 22% had received cytotoxic chemotherapy, and 27% received some other EGFR TKIs. So in total, out of two-third, only half of the patient they had received second line osimertinib. So what we can see is that almost one-third of the patient they had received osimertinib at some point of time in the first generation TKI arm. So these are the real world evidences which again reiterate the fact that the first lines osimertinib, so it is the standard of care, and it is seen that these patient also, so there are lesser number of second line osimertinib usage as compared to the FLORA trial. So this is the NCCN guideline which suggests that osimertinib is the standard of care therapy, category 1 option, first line in non-squamous non-small cell histology, where there are common EGFR mutation. And to conclude, osimertinib, it translated PFS to a significant OS benefit, and this was the first TKI which had shown the significant OS advantage. Osimertinib has shown very good CNS activity against those with baseline metastasis or those without baseline metastasis. So there were fewer CNS progression events which were observed with osimertinib as compared to the SOC EGFR TKI. Fewer and less severe adverse events were reported with osimertinib as compared to the second generation TKI. And osimertinib is the new standard of care for the first line therapy in EGFR mutated non-squamous non-small cell histology. With this, I would like to end my talk. If there are any questions, I'll be happy to answer that. So, if there are no questions, I would like to take this opportunity to invite Dr. Pankaj, who will be our next speaker. He'll be speaking on molecular biomarkers for testing in non-small cell lung cancer. Over to you, Pankaj.
Yeah, thanks a lot, organizers, for having me here. And the topic given to me is the biomarkers in lung cancer. I'll just share my slides. Hope my screen is visible. Is my screen visible?
Yes,
Yes, sir, it
Pankaj.
is visible.
Thank you. So, we'll have some updates on the molecular biomarker testing in lung cancer. And I think most of the things have been elaborated by Dr. Praveen already when he was giving that talk on osimertinib. So, the content will include lung cancer in India, biomarkers testing, evolution of biomarkers, past and the current, and the takeaways. So, the burden of lung cancer, as per Globocon 2020, we know that it comprises 8% of the new cases across all ages in males, and one of the top three cancers as far as prevalence is concerned in males. 50% of patients with advanced non-squamous NSCLC have a driver mutation with an FDA-approved agent or clinical trial. So it's traditional that we wait for these mutations before we jump on giving chemotherapy, immunotherapy, and all those type of drugs. So we are having plethora of agents. If we talk about ALK inhibitors, we have crizotinib, alectinib, ceritinib, lorlatinib, and brigatinib. EGFR, age-old gefitinib, erlotinib, followed by afatinib. Then we had this osimertinib and decometinib, and I think osimertinib still holds one of the best drugs, as Dr. Praveen has just talked about. Then we have this KRAS inhibitor, sotorasib. We usually get it on compassionate grounds. ALK positivity is 7%, which you are talking about, and EGFR positivity, we know it depends on the region. Then HER2 mutations 2%, ROS mutation 2%, BRAF 2%, BRAF 2%, and PIK3 1%. Then we have this for HER2 trastuzumab which is a effective therapy. MET inhibitors, capmatinib and tepometinib. ROS inhibitors, we have crizotinib and entrectinib. RAF inhibitor, dabrafenib. RET infusion inhibitors, selpercatinib, which again on compassionate grounds we get. NTRK fusion inhibitors, lotrectinib. So we see that overall survival among these patients who have driver mutations is far better than the patients who are wild type. So in the wild types, still the survival remains around a year. But in the patients who have these driver mutations, the survival is on an average 18.6 months. So guidelines recommend routine biomarker testing to guide treatment decision in advanced NSCLC. And depend upon what guidelines we follow, we may ask for a NGS, which covers everything as far as NCCN is concerned. However, ESMO is a bit more conservative, basically focusing on EGFR, L-cross, RAF, NTRK, and PDL1. So these NCCN and CAP guidelines also suggest testing of KRAS mutations, as presence of KRAS indicates poor patients, and patients with KRAS are unlikely to benefit from other molecular testing. So KRAS also should be preferably done. And ESMO and NCCN guidelines include additional biomarkers that should be tested based on data that was not available with CAP. So method of testing in NSCLC, we have either the NGS, which is now most commonly used, detects insertions, point mutations, and detects deletions as well. Detects aberrations in EGFR, KRAS, BRAF, HER2, MET. RNA sequencing panel detects fusion abnormalities, more sensitive for ELK, ROS, RET. Then we have IC fish, ELK. We still preferably test with the fish because we get early results. And this detects ELK, ROS fast, but then it's not that reliable. So tissue journey, biopsy tissue always have been an issue. We can have either resection specimen, small tissue specimen, fine needle aspirations, exfoliative cytology. Then we can have it from the cells shed from the body surface like urine, ascitic fluid, pleural fluid, sputum, CSF, liquid biopsies from blood and cyst fluid. And the people who are involved are usually the surgeon, pathologist, allied health professionals. Histology, again, assessment methods can be either PCR, and we can have this DNA for this MSI and WES analysis. And RNA, we have again RT-PCR and gene expression panels. We can also use proteomics to detect these anomalies. So, test of EGFR, L, cross, RAF, RTK, MET in all non-squamous should be done. Test of PDL expression again in all NSCLC should be preferably done. ctDNA testing has the potential to be applied across all stages of NSCLC, and it also helps in diagnosis and treatment selection. And ctDNA genotyping is recommended for clinical use in advanced NSCLC to guide treatment selection under specific circumstances. In resectable NSCLC, ctDNA testing is not part of current clinical recommendations, but may be applied in future. It also helps in monitoring the prognosis and response to treatment, as there are potential applications to detect early progression or recurrence. But then there are heterogeneity and tumor changes over time. So we have to have more data. So ctDNA cannot replace the biopsy, but can be playing a complementary role in the treatment selection. So it can be used to detect MRD after surgery. So we can know which are the patients who are having more chances that they will relapse. So in the tracer study, ctDNA profiling was able to confirm MRD negativity and detect MRD in patients who relapsed before the disease was picked up. So presence of MRD may be used to predict disease recurrence. It cannot be identified using traditional diagnostic methods. A detection of ctDNA in plasma indicates the presence of residual tumor. It can be used to measure the MRD. And this was also seen in the tracer study. 93 of the patients with disease recurrence were actually MRD positive, and 90% of the patients without recurrence were MRD negative. So it was that specific. So comparison of tissue versus liquid biopsy. Tumor tissue, simple acquisition, we know invasive surgical procedure is there, liquid non-invasive. Repeat sampling is difficult, liquid biopsy we can. Tumor tissue correlation with the histology is good, while in case of liquid biopsy, direct correlation between ctDNA results in histology or cell type not possible. Sensitivity, lower tumor cell content acceptable, and liquid is very sensitive method required, as ctDNA may compromise only less than 0.1%. Then this tumor tissue uses validated tissue processing, while standards of analytic performance characteristic of ctDNA have not been established yet, and there are no guidelines which exist regarding the recommended performance characteristic of liquid biopsy. Substantial evidence of initial target therapies are there as far as solid biopsies are concerned, but it is increasing liquid biopsies. But if we talk about today, it's less. So multiple genes are involved in NSCLC, and single gene reflex testing or multiple genes testing by NGS can be done. So we can do all these required tests by single gene testing or the NGS, EGFR, ELK, ROS, and all these tests, KRAS, and that's what you're talking about. So advantage of NGS has a number of advantages. As a number of clinically actionable biomarkers have increased, the ability to evaluate all molecular alterations in a single test has given NGS a major advantage. If one or more molecular markers are needed, higher costs and longer turnaround will be there versus a single gene. But if many molecular markers are needed, it reduces the total cost. So NGS detects broad range of molecular alterations, but has high complexity of workflow. And advancements in the field of NGS are again evolving. So we have these tests. If you see the types of genomic aberrations, EGFR frequency is 30 to 40, and we have these drugs available, afatinib, osimertinib for this. It can be detected by PCR or NGS. Then KRAS again, PCR or DNA sequencing is needed. MET amplification, L can be tested with a IC. Then BRAF again, PCR, ROS fusions. We have this diagnostic approach, and we can use crizotinib. Similarly, RET and NTRK genes can also be analyzed. EGFR mutations in lung cancer needs fresh sections, frozen or alcohol-free specimen for the PCR-based assays. Cytological samples are also suitable. Cell blocks are preferred over the smears. And the primary tumor, we see the EGFR positive were 108. So these are the studies of concordance of EGFR mutations versus metastatic tumors. So EGFR positivity, concurrence positive was 108 in both. But if patient has primary tumor was EGFR negative, then the metastatic lesion only 6 were there which were positive. So you can say around 2 to 3% discordance is there in the primary tumor versus corresponding metastatic site. Then EGFR molecular testing in early lung cancer, NCCN recommends to test it in early lung cancer also because we have therapeutic consequences if the patient is having an EGFR mutation, where we can offer these patients osimertinib in the adjuvant setting post-surgery. Then advantage of NGS over PCR, study showed that 48.6% of EGFR identified were missed by PCR. Out of 17 most common EGFR mutations variants, only 4 can be identified by PCR. Then ELK arrangements, in most cases, ELK IC is 93 to 100% sensitive. And these are the various studies in which we see that IC is quite sensitive as far as test is concerned. And very less number of patients will be there who are IC positive and FISH, IC negative and FISH positive. And false positivity is 0.1% with FISH. IC is less expensive, hence more widely adopted. Then we have these ROS mutations. Again, they can be ROS positive or negative, reconfirmation by a second method. That is, FISH is required if patient is IC positive. And if we are doing directly FISH, then reconfirmation by a second method, that is IC and other molecular assay is required. So both these should be positive to declare a patient a ROS positive. Then KRAS mutations are mutually exclusive with EGFR and ELK and account for 30% of lungs. So we have a drug, sotorasib, is currently approved for these patients. And there are trials of newer drugs also for this early phase 3 or 2-3 trials. Single gene KRAS testing is not currently recommended and should only be performed as a multi-gene panel. Then BRAF mutations present in 600E in most of the BRAF mutations. And we have non-600 mu mutations also. Overall, BRAF mutations occurs 1 to 5%. And resistance generally develops that bypasses RAF, such as redirection of cell signal. Currently approved drugs are dabrafenib and trametinib for these mutations. Not widely accepted as single gene, but as an NGS. Then we have MET exon 14 mutations in SCLC. Normal splicing versus aberrant splicing and exon 4 regions are there. And we should know because MET skipping mutations can be detected with DNA NGS, but increased sensitivity is there with RNA NGS. Then again, this RET should be tested by NGS. And most of them can be detected by DNA NGS, but increased sensitivity with RNA NGS. RET can be checked by IC, FISH, DNA NGS, but IC is not recommended. Recommended is basically NGS by DNA or RNA. Anti-RK inhibitors are also available and reflexing to NGS versus IC reasonable for NSCLC, but there is low prevalence of anti-RK. So use frontline NGS preferably with RNA testing when possible. Advantages of IC are rapid, detects low cost, widely available. Fish again rapid, but NGS, their potential of multiplex testing, less depletion of tissue, fusion partner and position can be identified, and this is very sensitive. Only problem is the longer waiting time and the cost. Then the her mutations and amplifications can be identified using NGS. So these are the summary of whatever we have talked about, various mutations and the target drugs which are available, which can be used. Then the PD-L1 expression, we have various platforms for various drugs, and there are different scoring system also. Like if you want to use pembrolizumab, we have DACO 22C3, for durvalumab SP263, atezolizumab 142 SP. So we have again the scoring systems are different, like PDL1 positivity, then the tumor cancer cell ratios, TC ratio is also assumed. Different antibodies are used for these, like SP263, 22C3, SP142. So this is a controversial topic, that whether they can be interchanged if one platform is used, whether that will be valid for another drug. Biomarker testing in NSCLC has evolved over single gene to multiplex testing. Multidisciplinary meetings help in better understanding. Sample should contain adequate tumor, and the turnaround time should be preferably 10 working days. High platforms such as NGS can be used to screen several genes at a time. Then clinical guidelines strongly recommend broad molecular profiling to identify rare driver mutations for which effective drugs may be available, or to appropriately counsel patients about available clinical trials. Broad molecular profiling is a key component of the improvement of care of the patient with NSCLC. With that, I'll conclude, and thanks for patient hearing, and thanks for giving me this opportunity to talk about this molecular advancements in NSCLC. Over to Dr. Manish for the next speaker.
So next, we would like to call Dr. Abhishek Yadav. Dr. Abhishek has joined.
No, sir, he haven't joined yet. He will join in 5 minutes.
So talk to Dr. Abhishek or Dr. Manish, who will be doing the next.
Manish, sir, can you do?
So please speak with Abhishek. We will wait till Abhishek joins.
Okay, sure, sir.
Abhishek is joining in a minute.
Okay, sir.
Dr. Abhishek. Dr. Abhishek?
Sir, he haven't joined yet, joining in 2 minutes.
I think if Abhishek has not joined, so you can start. I
Yeah, he is joining in a minute. I
think.
called him.
Sir has joined, sir.
Dr. Abhishek?
Am I audible?
अरे अभिषेक हमें लगा था तुम बाईपैप के साथ करोगे.
ये रहा देखो.
So I invite Dr. Abhishek for his next talk on the overview of lung.
Can you share the slides, please?
Yes, sir.
So thank you for having me here, organizers, and thank you, Dr. Manish. So we'll be discussing an overview of lung cancer, the important things about the prevalence, the incidence, and the diagnostic workup, and how to proceed with the different stages for the different kinds of treatment. So we can see that according to Globocon 2020, it is the second most common malignancy amongst males in India, with around 51,675 cases occurring annually. And it is, if we see both the sexes, then it ranks fourth after breast, oral cavity, and cervix, with total number of 70,000 cases in both the sexes. Next slide. So we can, as we next slide, please. So as we see that AJCC 8 staging, previous slide, please. So we can see that the staging was changed from AJCC 8 to AJCC 7 to AJCC 8, in which the tumor size of more than 7 was still counted as stage 2 if it was node negative, whereas in the uh, AJCC 8, the tumor size of more than 7 centimeter, that is a T4 tumor, is counted as stage 3 in spite of node negative status. And in terms of N2 disease also, we can see a change whether whether the disease is stage 3A or 3B. Next slide. So investigative tools for staging are bronchoscopy, CECT chest, PET-CT, EBUS, EUS, mediastinoscopy, and MRI brain. Next slide. So what to prefer, contrast enhanced CT chest versus a PET-CT for staging in stage 3 NSCLC. So if we see any lymph node which is more than 10 mm in short axis, it predicts to be involved by a malignancy. So CT scan alone has a limited role due to low sensitivity of 55% and low specificity of 81%. But it may help in selecting appropriate procedure for tissue sampling by providing the images. So addition of PET-CT to CT provides an overall sensitivity of 80 to 90% and a specificity of 85 to 95%. So with addition of PET, we can see that both specificity and sensitivity are significantly increased. Next slide.
Hello, Dr. Abhishek.
Sir, I guess he has some network issues. He is joining again.
Okay.
Am I audible?
Yes, Dr. Abhishek, audible.
Sorry, there was a problem with the internet. So, next slide, please. Next slide. So, the mediastinal staging can be performed by EUS and EBUS, which are less invasive, and the invasive are the mediastinoscopy. Next slide. So we can see that the recommended techniques are EBUS and US. If clinical suspicion of N2 involvement remains high, even after a negative EBUS or US, then surgical staging with a mediastinoscopy is recommended. As we have already seen, if the tumor is central, has a very high SUV uptake, and is bigger in size, that is more than 4 or 6 centimeter, and if EBUS and US are saying that the mediastinum is negative, then a mediastinoscopy is recommended to be doubly sure. So there are total 14 lymph node stations, and we can see that the first is the supraclavicular zone, that is the N3, and the second, third, and fourth are the superior mediastinal nodes. And the fifth and sixth are the aortopulmonary zone. Seventh, eighth, ninth are the inferior mediastinal nodes in subcarinal and the lower zones. And the hilar interlobar and the peripheral zones are the 11, 12, 13, and 14. Next slide. So when is invasive mediastinal staging indicated? So a centrally located tumor more than 3 centimeter in size, extensive infiltration of the mediastinum with no evidence of extrathoracic disease and positive N1, bulky N2 on CT, no need for invasive confirmation if we have a bulky N2 on CT. And if we have a discrete N2, then yes, we need to do a mediastinal staging irrespective of the PET-CT result. And normal mediastinum on CT, but positive on PET, yes, we have to do it. But negative on PET, no, we don't need to do it. Next slide. So this is the mediastinal staging algorithm protocol, of which with the salient features we have already discussed, that if the PET-CT with intrathoracic lung cancer with or without enlarged lymph nodes, so mediastinal lymph nodes are positive in the negative in the PET-CT, and CN0 and low probability of unforeseen N2 disease after negative PET-CT, then we can go ahead with the surgery or radical radiotherapy. If clinically that is the disease is N1 or N0 and high probability of unforeseen N2 disease after negative PET-CT, then definitely tissue confirmation by EUS and EBUS is required. And if the mediastinal lymph nodes are negative, we proceed for surgery. And if mediastinal lymph nodes are positive, then we need to go for the multimodality treatment. If mediastinal lymph nodes are positive in the PET-CT, then we have to see whether the lymph nodes are bulky or non-bulky. If there are non-bulky, then we need a tissue confirmation by EBUS or EUS. If there is a bulky lymph nodal disease, and then no tissue confirmation is required. Next slide. We can see that by which modality of the mediastinal staging, which group of lymph nodes are most easily accessible. We can see that it is TEMLA and it is the US FNA which can sample most of the stations. But the most common modality that we do is EBUS TBNA, which is not good for station 3A, 5, 6, 8, 9. Next. So we can see that as we go up from CT scan to PET and then EBUS, EUS, then mediastinoscopy, then if we combination of EBUS and EUS, and a combination of EUS plus EUS plus mediastinoscopy, then the sensitivity goes on increasing. So we can achieve almost a 94% sensitivity with a combination of EUS, and the mediastinoscopy. And with VATS, we can almost be 99% sure. Next slide. So this is how evolution of therapy in lung cancer took place. NSCLC was considered a single disease until distinct subtypes characteristics were identified. NSCLC subtype characteristics are clinically relevant for treatment planning from diagnosis. NSCLC and SCLC, then NSCLC, there's a histological breakdown in the large cell adenocarcinoma, squamous cell carcinoma, and non-squamous carcinoma, and the molecular pathology of EGFR-L cross1, PD-L1 expression, and tumor mutational burden. Next slide. Advances in media management of NSCLC have improved survival that we have all have seen in our practice. Lung cancer specific survival improved from 26% among men with NSCLC that was diagnosed in 2001 to 35% among those in whom it was diagnosed in 2014. So there is reduction in incidence along with treatment advances, particularly approvals for and use of targeted therapies. Next slide. So there is a significant increase in approvals of both targeted as well as the immunotherapy in NSCLC that we have seen. So this is the timeline in which the therapies evolved. In 2006, it was chemotherapy with bevacizumab for non-squamous NSCLC. In 2009, platinum with pemetrexate became the preferred therapy for adenocarcinoma. Then crizotinib was introduced in L positive in 2011, then erlotinib in EGFR positive in 2013, and from 2015, this development has been very rapid from involvement from approval of gefitinib to ceritinib, and in 2020 we have capematinib, selpercatinib, and brigatinib, and entectinib for various rare mutations like NTRK, MET fusion, and the RET positive NSCLCs. And for insertion 20 mutation, there came up the role of amivantamab very recently, and then probably immunotherapies starting from pembrolizumab in 2016. Later on, then approval of atezolizumab as well, and ipilimumab and nivolumab combination. Next slide. So, if we see the molecular complexity of the adenocarcinoma, then the most common mutation that we see is KRAS mutation, followed by the EGFR mutation, followed by ALK fusion. Then there are many rare mutations like NTRK, HER2, BRAF, PIK3CA, HRAS, NRAS, AKT, MET exon 14, MAP3K, and but still, almost half in half of the cases we don't know what exact molecular aberration leads to the formation of adenocarcinoma. So there are now 7 molecular alterations with FDA-approved targeted therapies like EGFR, ALK, ROS, BRAF, NTRK, MET exon 14, and RET. This increases the need for molecular testing in a CLC. Molecular testing should be standard of care in a CLC now. Next. So stage 1A and 0 no lymph nodes, recommended chemotherapy treatment in terms of neoadjuvant and adjuvant chemotherapy depending upon disease stage and findings during surgery. 1A and 0 observation, 1B, 2A, no lymph nodes, multidisciplinary team discusses observation versus adjuvant chemotherapy for high-risk patients. No proven benefit of neoadjuvant chemotherapy. Stage 2B and 0 or N1 lymph nodes, adjuvant chemotherapy is recommended. No role of neoadjuvant chemotherapy in stage 3 and 3B, N1 and N2 lymph nodes, neoadjuvant chemotherapy or adjuvant chemotherapy or sequential chemotherapy. So findings at surgery and surgical resection margins affect the adjuvant treatment decisions. Resection margins as well as pathological stage affect the adjuvant treatment decisions. So potential resection outcomes are negative margins, no residual tumor. Then it can be a positive margin, that is microscopic residual tumor, that is R1 resection, and the macroscopic residual, that is R2 resection. So in stage 1A, 2A, complete resection, we need observation. Chemotherapy can be given for high-risk patients 1B, 2A. Incomplete resection, then if there is incomplete resection, that is R1 or R2, a re-surgery is preferred, or radiation plus chemotherapy is preferred. For stage 2B, chemotherapy definitely for a complete resection, or and re-resection plus chemotherapy or CTRT for incomplete resection. In stage 3A and 3B, chemotherapy and sequential chemotherapy plus RT. That is for anti disease only. And if there is R1 resection, then uh, chemotherapy followed by radiation, sequential or concurrent. But if it is an R2 resection, then definitely concurrent CTRT is the preferred adjuvant treatment. Next slide. After initial treatment, more than half of the patients with resectable NSCLC experience recurrence within 5 years. So around at 5 years, only around 50% remain cancer free, and around 50% they have a recurrence, whether local or distant. So we see that overall outcomes still need to be improved for patients with resectable NSCLC. Next slide. So latest ESMO guidelines recommended adjuvant chemotherapy can be considered in patients with resected stage 1B disease and a primary tumor of 4 centimeter due to clear evidence of benefit. However, since these guidelines were published in stage 1B tumors of more than 4 centimeter have been reclassified as stage 2 in the 8th edition of TNM staging, therefore adjuvant therapy is now the standard of care for these patients. Adjuvant chemotherapy may remain an option for patients with stage 1B disease, 8th edition of TNM staging, who have a high risk due to factors other than tumor size. Next slide. So LACE meta-analysis shows OS benefit from post-operative cisplatin in early stage NSCLC. So this meta-analysis was a pooled analysis of 5 trials. So hazard ratio was 0.89 and absolute benefit of 3.9 and 5.4% was observed at 3 and 5 years follow-up. Next slide. So how well does a neoadjuvant chemo work? About the same as adjuvant. So we can see that for stage 1B to 3A, the neoadjuvant chemotherapy had an hazard ratio of 0.87 and an adjuvant chemotherapy had an hazard ratio of 0.89. So preoperative chemotherapy fared better in few cases, and in other cases the slide is too small. I'm not able to. So in the various trials like France, in MD Anderson, Spain, MIP, SWOG, JCDG, Netherlands, Finland, MRC, SWOG, China, and the NACH, these are the various trials in which the preoperative chemotherapy percentage were 8 out of 13, 19 by 28 in various, and in the control regimes were there. And we can see that in few cases, the preoperative chemotherapy found to be beneficial, and in other cases, the adjuvant chemotherapy was found to be beneficial. Next slide. So, improving survival in resected EGFR and SCLC, targeted therapy is now moving to early stages. So, ADORA trial improved DFS was seen with osimertinib in resected EGFR mutant NSCLC, and the patients that were included were completely resected, stage 1B, 2, 3A, exon 19 deletion or L858R mutation, total number of 682 patients, osimertinib versus placebo. Patients were followed for 3 years for recurrence, and we see that there's 80% reduction in the risk of disease recurrence and death with osimertinib in the adjuvant setting. So it is now also possible to further improve survival in completely resectable stage 1 to 3 NSCLC by addition of TKIs. Next slide. Atezolizumab showed an improvement in DFS as well as OS in the adjuvant setting. Atezolizumab showed an improvement in survival in adjuvant setting in patients who had PDL1 of more than 1%. and the median DFS was 95%, and stratified hazard ratio was 95%. And we can see the clear separation of curves. This is the DFS curve over the month from very beginning till the follow-up of around 54 months. Next slide. So lung cancer edition 2022, advanced technologies have led to safer treatment. IMRT has been shown to improve survival for patients with stage 3 NSCLC, reduce dose to heart with lower rates of grade 3 or more pneumonitis, increasing dose to heart associated with higher risk of death in stage 3 NSCLC. Next slide. Semantics for radiation. What is relevant to the pulmonologist? Important to differentiate between stereotactic body radiation therapy versus conventional fractionated EBRT, which for stage 3 NSCLC is typically IMRT technique. SBRT is high dose fraction, 1 to 5 fractions with the 3 target location, especially in patients who have a localized disease but are unfit for surgery, but cannot be used for patients who have more than 5 centimeter tumors and with the N2 nodes. Next slide. So 4D CT planning allows for margins around the tumor to be minimized. Image-guided IGRT ensures accurate target coverage. Adaptive radiation, creating a new radiation plan for after tumor target volumes have reduced in size, allowing for normal tissue sparing, which can be done in midst of the radiation therapy, and results smaller target volume with lower doses to normal tissues, including lung, esophagus, and heart, to minimize the side effects and maximize the benefit. Next slide. So contemporary RT techniques in stage 3 NSCLC, long-term OS results from RTOG 0616. Phase 3 trial evaluated standard dose versus high dose CRT plus cetuximab in stage 3A or 3B NSCLC. 5-year OS of 32% with high quality standard dose RT. No role of RT dose escalation, no benefit of cetuximab addition was seen. Now even better results when immunotherapy added to CRT backbone. Stage 3 NSCLC is a potentially curable disease. Next slide. So chemotherapy with or without radiotherapy standard of care after complete resection in patients with stage 3 NSCLC. So in for patients with stage 3 disease, the medical oncologist should work closely with the radiation oncologist and radiation radiologist to ensure a coherent approach. Some otherwise eligible patients may be unfit for chemotherapy due to factors such as very advanced age. Not all patients will complete their prescribed course of chemotherapy. So pathological stage 1A, observation 1B and 2. A multidisciplinary team to discuss observation versus chemotherapy, but 2B onwards, definitely chemotherapy. And for 3A and 3B, chemotherapy or sequential chemotherapy plus radiotherapy. Next slide. So checkpoint inhibition is moving to early stages. In unresectable stage 3 NSCLC, the Pacific trial, it is a double-blind placebo-controlled phase 3 trial of consolidation durvalumab in unresectable NSCLC. And we all have seen a very good benefit with this strategy. And at the end of 6 months, we have seen that there is 42.9% probability of survival in terms of in the durvalumab arm in comparison to 33.4 months in the arm in which only radiation was given, only CTRT was given. Next slide. So durvalumab, as we have seen, durvalumab demonstrated a 42.9% OS at 5 years and comparison to historical OS in unresectable stage 3 CLC of 15 to 25% only. Next slide. So emerging treatment paradigms in NSCLC, targeted therapies and immunotherapies. Next slide. So targeted therapies are improving outcomes in advanced NSCLC. Flora trial, we have seen that for the first line osimertinib versus first generation EGFR TKI, there is a huge difference in the survival, with the median survival of osimertinib around 19 months and with first generation TKI of 10.2 months only. That ratio of 0.46. And in the Alex trial with alectinib versus crizotinib, we can see the median OS of 34.8 versus 10.9 months. Next slide. So for MET exon 14 alterations, the incidence is 3 to 55%. Exon 14 skipping, more common in adiplasoma, can be targeted with quizartinib. Ret rearrangements can be targeted with cabozantinib and vandatinib. And latestly, by the drug called selpercatinib. I have a patient on the selpercatinib. The patient is doing fantastic since last 1 year. Anti-RK rearrangements can be targeted with larotrectinib and entectinib. HER2 mutations can be targeted with TDM1. So new targets are being identified. This will help increase the survival of these subset of patients. Next slide. With recent advances, survival rates are improving compared to the chemotherapy alone. Next slide. Immunotherapy in NSCLC immune checkpoint inhibitors. So body is using own immune cell to fight the cancer. So it can be a CTLA4 blockade, or it can be a PD1 or a PDL1 blockade. Basically, both of these strategies lead to T cell activation and killing of the tumor cells. Next slide. So approvals of ICI over time in 2015, the approval of pembrolizumab in 2018 came the durvalumab in stage 3, and atezolizumab came up in 2019 with carboplatin and nab-paclitaxel, and with the atezolizumab in adjuvant setting, and the nivolumab and ipilimumab in the first line metastatic NSCLC in 2020. Then semipilimab in first line metastatic NSCLC or locally advanced NSCLC, ineligible for resection and definitive CRT with patients of PDL1 score TPS more than 50%. Next slide. So we have seen that the survival outcomes with immunotherapies have been significantly better. Next slide. So checkpoint inhibitors have improved survival in advanced NSCLC. We can see the survival curve over months. Then we can see that significantly higher number of patients were alive at 36, 48 at 60 months of follow-up in the immunotherapy arm in stage 4. Next slide. So Keynote 024 showed an improved survival benefit with pembrolizumab compared to chemotherapy with PDL1 TPS more than 50%. Almost 32% patients were alive at 5 years with the use of IO in metastatic NSCLC. Next slide. So checkpoint inhibition is moving to early stages in resectable NSCLC as adjuvant and neoadjuvant therapy. Multiple ongoing trials are in adjuvant setting, like Pearl's Keynote 091 of pembrolizumab, BR31 of durvalumab, and Anvil of nivolumab, IM Power 0101 of atezolizumab. Next slide. What is new in NSCLC? Approved therapy in breast cancer, upcoming in NSCLC, antibody drug conjugates. So this is something new to So antibody drug conjugate binds to the antigen, the payload or the chemotherapy drug bound to the antibody is delivered to the inside the cell, which then goes and interacts with the DNA, and the microtubule inhibition takes place. Next slide. CAR T cell therapy is again a new era in cancer immunotherapy in which the genetic T cells of the body are harvested, then exposed to specific antigen, tumor-specific antigen, and then their T cell receptors are genetically modified by using a virus, and then they are multiplied and grown in the lab, and then they are infused to the patient's body, where they kill the with kill the tumor cells very rapidly. Next slide. So key takeaways are that the management landscape is fast changing. Newer therapies have a huge potential to improve survival, especially in early stages. The OS has improved across various subtypes with molecular alterations. The ease of oral pills over infusions in case of targeted drugs is an added advantage. Pulmonologists will play a huge role in early diagnosis, hence it's crucial to involve them in NSCLC treatment boards. Thank you.
Thank you, Dr. Abhishek, for that wonderful presentation. So next, I will be speaking on the adjuvant treatment of NSCLC. Can you please share my slides?
Yes, sir.
So I'll be speaking on reinventing adjuvant therapy in EGFR mutant early lung cancer. Next slide. So lung cancer is a leading cause of cancer death, around almost accounting for 1.8 million deaths annually. And NSCLC represents approximately 80% of all lung cancer diagnosis, with an estimated 30% of the patient presenting with a resectable disease at diagnosis. But the global 5-year survival rates in NSCLC with resectable disease is 65 to 75% in 1B stage, 50 to 70% in stage 2, and 30% to 45% in stage 3A. So as the stage progresses, the global 5-year survival rates with resectable NSCLC decreases. Next slide. So this is the expert consensus recommendation on the biomarker testing in metastatic and non-metastatic NSCLC. So those patients who have non-metastatic NSCLC, resectable lung cancer, they should undergo EGFR and PD-L1 mutation testing, and then they should follow the approved treatment recommendation, which we'll be discussing in a short while. Next slide. So current testing and treatment pattern, prevalence of EGFR mutation in patients with resected stage 1 to 3 non-squamous NSCLC. This is a result from early EGFR study presented in ASCO 2023. And it was found that EGFR mutation prevalence was 51% in resectable stage 1 to 3 non-squamous NSCLC. And the most common was deletion 19, which was 50.5%, followed by L858R, which was 36.0%, and then TDA T790M mutation, 3.3% patient, then few patient had compound mutation and uncommon mutations. Next slide. So this is the prevalence of EGFR mutation uh, uh, in the patients who had stage 1 to 3 non-squamous NSCLC result from early EGFR study. And these are the treatment patterns. Only few of the patients with stage 2 or stage 3 NSCLC will receive adjuvant systemic treatment, that is 46.3% patient. Next slide. So after initial treatment, more than half of the patient with resectable NSCLC would experience recurrence within 5 years, and the 40 to 50% patient, they will remain cancer free, while 50 to 60% patient, they will have cancer recurrence within 5 years of the treatment. So given that over half of the patient recur after curative intent surgery, there is unmet need for improved neoadjuvant and adjuvant treatment options in order to improve outcome. Next slide. So this is the Anita study, adjuvant chemotherapy after surgery for stage 1B to 3A NSCLC, and it showed that the adjuvant chemotherapy with cisplatin based combination, it improves the survival by 5% after 5 years of the treatment finishing. Next slide. So these were the few of the select studies with EGFR TKI in adjuvant EGFR mutation NSCLC setting. Almost all of them showed DFS benefit, but one of them did not show DFS benefit, which was BR19 with gefitinib. But other than that, select study with erlotinib showed 2-year DFS of 88% versus 76%. Radiant trial with erlotinib showed meaningful DFS benefit of 46.4 months versus 28.5 months. Ivan study with erlotinib showed similar DFS benefit, but none of them showed overall survival benefit with the EGFR TKI in the adjuvant setting in NSCLC. Next slide. So this is the current evidence for EGFR TKI from the randomized trial, adjuvant EGFR mutation NSCLC setting. All of them showed improved DFS, but no overall survival benefit. Next slide. So why these data did not change the clinical practice? Because the trial to date have been limited by design size and other factors, no overall survival benefit. Unclear if adjuvant EGFR TKI results in cure or it delays recurrence only, and no definite evidence on appropriate sequence, drug, or duration of the treatment. Next slide. So this was the ADORA trial. This is phase 3 trial, which included patients who had completely resected NSCLC stage 1B, 2, or 3A with or without adjuvant chemotherapy. Key inclusion criteria were more than 18 years of age, PS of 0 to 1, confirmed primary non-squamous NSCLC, exon 19 or deletion, or L858R mutation, brain imaging showing negative margins, or if there was a tumor preoperatively, and then the interval between the surgery and randomization should be 10 weeks if no adjuvant chemotherapy given, and 26 weeks if the adjuvant chemotherapy was given. These patients, they were randomized to osimertinib 80 milligram once a day or placebo once a day, and the treatment duration was 3 years. The treatment discontinued if disease recurrence happened, or treatment completion happened, or discontinuation criteria met. Next slide. So ADORA significantly improved DFS as compared to the placebo in the primary as well as overall population, stage 2 to stage 3A or overall population. You can see that the hazard ratios, they are extremely significant to the tune of 0.23 in stage 2 to stage 3A, while 0.27 in overall population. Next slide. It also improved CNS DFS. CNS metastases are a poor prognostic factor amongst patients with NSCLC and are associated with deterioration in the quality of life. Improved CNS efficacy with osimertinib treatment. Osimertinib has shown greater penetration of blood-brain barrier and higher exposure of brain compared with the other EGFR TKI. Adjuvant osimertinib demonstrated CNS DFS benefit with placebo in both stage 2 to stage 3A and stage 1B to stage 3A population. On the right hand side, you can see the Kaplan-Meier curve for the same. ADORA updated CNS DFS analysis, and the hazard ratios, they were statistically significant. It was 0.24 in the patients who received osimertinib as compared to those patients who received placebo. Next slide. So no new adverse events were noted when compared to the primary readout of the ADORA trial. Next slide. So in order to improve survival, we need to put more efforts to identify lung cancer early. Never miss the opportunity to test for an actionable mutation. And now this applies in EGFR lung cancer also, especially for EGFR, and the collaboration with multidisciplinary team is key to improve survival. Next slide. Patient may ask for treatment option for the best survival probabilities. Be ready to discuss and offer them as per the best available data. ADORA trial gives a probability of patient to remain cancer-free for long with survival benefit. Being cancer-free is goal for patient as well as for the treating physician. Next slide. Thank you so much for your patient listening. If there are any questions, we can take a few questions. So if there are no questions, I think we can close the meeting. Thank you so much for the joining this evening on the updates on the lung cancer. Good night.
Thank you so much, sir, for
Uh, Thank you everyone for joining. Thank you, Samar. Thank you, support team.
Thank you, ma'am.
Support team, close the meeting.